But then when they're reviewing and studying or whatever, instead of having to just think back in their mind to what it looked like or look at still images or whatever, you can just have a model available and you can see a very high resolution example of whatever pathology you're trying to see. Uh, Tumor board, this is definitely is something we do as well of these models of the tumor board. If you're saying the margin is less than zero point 0.1 centimeters, you could just show them, hey, here's the slide. This is what I'm seeing. This is the exact spot on the specimen where it came from. And so if they're planning to re-resect or whatever, you can be much more granular with where you're telling them you're positive. You're not saying, oh yeah, it's somewhere on the medial. You're saying, hey, this is block M. I'm showing you exactly what it relates to. And then everyone in the call can just see this is exactly where the margin was positive.
Welcome to the People of Pathology podcast. I'm Dennis Strank. On this podcast, we explore pathology one story at a time and connect with the people behind the diagnosis. It's sometimes difficult to accurately document complicated tissue specimens using just the words of a gross description and static photographs. So, what if we had a better way? Today, we're diving into the intersection of technology, surgery, and pathology with Dr. Michael Topf and Dr. Alexander Perez. Their team is pioneering the use of affordable 3D scanning and mapping technology to create detailed digital models. All right, let's get into this innovative technique with Dr. Alexander Perez and Dr. Michael Topf. This is going to be a really interesting topic and something that I'm actually personally interested in, so I'm excited to talk about this. I want to start with you, Dr. Topf. Can you tell me about your career path into head and neck surgery?
Yeah, thanks for the question. I chose otolaryngology, head and neck surgery as a medical specialty, and very early on realized that I was drawn to the head and neck cancer patients as well as just the overall field of oncology, both medical and radiation and surgical. And that led me to pursue an advanced head and neck surgical oncology fellowship through the American Head and Neck Society after my residency. And then now I'm faculty in my 6th year of practice. But really, I was drawn to cancer care because of the patients.
That kind of goes along with a lot of the episodes I've been doing lately. They've been more looking at pathology, but more patient focused. So I like that kind of perspective, that point of view. All right, and then we'll go over to you, Dr. Perez. So you're the pathologist here. What was your path into pathology?
Yeah, so I got exposed to pathology actually really early in my life. So my mom is a medical lab scientist, and so she used to bring me to her lab for take your kid to work day, whatever, when I was a kid. So my whole life, I just remember doing that each year, and I really loved looking at the microscope. So she snuck home like an old Reichert for scope they were going to throw away at the hospital, and so she would let me squish bugs and look at those, or she would bring home like peripheral blood smears, whatever. Obviously, I had no idea what I was looking at, but she got me exposed to the microscope, and I just loved it. So when I was in high school, we had to do a project where you kind of try to pick a career you're interested in. You have to do a presentation for the class, whatever, at the end of the year. And so I picked pathology. So as part of that, I did shadowing my whole senior year of high school using pathology she knew from her work, and I just loved it. So pretty much by the time I graduated high school, I knew the plan was go to college to get to medical school to pursue pathology. And then that's exactly what I did. I never had anything tempt me away from it. So I ended up in pathology now. So I did my residency here at Vanderbilt University, and then I did a 1-year fellowship at University of Texas MD Anderson Cancer Center in bone and soft tissue pathology, and now starting my first year as faculty back at Vanderbilt University. So this is my first couple of months in practice now as faculty here. And so I do bone and soft tissue, and I do heart pathology as well.
Okay, that's interesting. Now, the thing we're mostly going to talk about here, the two of you worked on a project together and published a paper on this that we're going to talk about quite a bit. And this is about 3D scanning of gross specimens in pathology. So I want to get to the origin of this. So what sort of challenges in traditional photography or surgical pathology documentation of specimens inspired you to explore 3D scanning as an option or a solution?
I can start with this one. As a surgical oncologist, it is literally my job to completely remove a head and neck cancer, typically in an en bloc fashion with negative margins. And when you have a colleague, a pathologist, who is reviewing a case and signing out the case, who is maybe saying, hey, there's a chance that you do not have negative margins. As a surgeon, you can almost feel attacked, or it just is a very challenging conversation to have. And these, particularly in head and neck, the anatomic specimens are just so three-dimensionally anatomically complex, and it can be really challenging to understand where a particular margin or section was taken from. And I just thought that it was crazy. I still think it's crazy that we don't have some sort of 3D model to those conversations in cases of closer positive margins.
Yeah, I can relate to that. At where I work, we get a lot of head and neck cancer specimens, and yeah, they're very complex. They're very how do I explain it? Like the margins are sometimes irregularly shaped, and the specimen isn't flat or even round. It's all different sort of. The geometry is weird, if that makes sense.
It does, and it's composed of a lot of different types of tissue,
Yeah,
right? Mucosa, glandular tissue, muscle, perhaps bone. So, and they're just very different. I would within head and neck, the only specimens that are kind of routinely the same to some degree, because they're partial pharyngectomies and thyroidectomies, but the ejectomy specimens, I guess, are oftentimes relatively similar. But other than that, these head and neck specimens, every single one is different.
And then from the pathology side of it, the biggest thing I've always had an issue with is how it almost feels like a game of telephone. Like you have a surgeon who's taking a specimen out, so they see it in situ, and they're usually assisted by radiology. So they have kind of an idea in their head of what they're going for. They take a specimen out. Then they, depending on their workflow, they either bring that specimen in themselves to the gross room or they just send it off in a container to the gross room. So you already have your first chance for a disconnect where the person who took the specimen out is just writing on a piece of paper, this is anterior, this is posterior, and then orienting the specimen. Someone else, totally separate, who didn't see it in situ, receives the specimen to the best of their ability with those instructions. They orient the specimen, then they're going to prosect it. Now, in most instances, it's either a medical trainee like the resident, or it's a pathologist assistant who is grossing the specimen. Now, there's a chance the resident could be present at the sign out for the specimen, but usually or sometimes not. So then they're doing their best to transcribe all the information they're seeing as they're sectioning the specimen and examining all the aspects of it into a document on a flat piece of paper. Sometimes they'll take some photographs. And then now a totally different person who probably never saw the gross specimen is going to sign that case out by looking at the gross description, reading what was written, and then piecing it together based on 10 to 20 glass slides that correspond to this description on paper. So there's a lot of opportunity for subtleties and nuances of the specimen to get lost in translation. And if you have images you can reference, that's great, but there's nothing like seeing the actual specimen. And so in terms of practicality, it's not always easy for the person who's going to sign up the case to see every gross specimen. People change service weeks, specimens will follow into the following week or whatever. But one thing that's durable is the 3D scan. If you make one, that just can exist in perpetuity, and then anyone can look at that when they're signing out the case. So that was really my biggest initial interest into this. And it wasn't my idea by any stretch. I stumbled upon it by coming into to see this bright medical student we had, Kayvon Sharif, who's now a resident at the Mayo Clinic in head and neck surgery. And he previously had experience with this. So he brought this idea up at Vanderbilt. And I just happened to stumble into the gross room to see one day while he was working on it. But I thought it was a fascinating idea. And so that's kind of how I got involved with it. And I thought it answered a lot of the concerns I had in general about pathology reporting. And so that's how I got involved in this. And I've really enjoyed being involved in it.
Yeah, when you, as you were saying that, again, I can relate to all of that, and you're completely right. And listening to it out loud, it seems like, of course, there should be a different way to do this. This really isn't the most accurate way to describe a specimen. And of course, once you gross a specimen like that, you can't go back to it because it's sectioned pretty well. You can't, a lot of times you can't really put it back together.
Correct. And I'll just add it also, there are medical handoff errors that are occurring in our orientation and processing of our specimens that we just do not know about, right? We're actually uncovering them now that we create these models, and surgeons who are in the operating room and get to see the specimen in vivo and also reference radiologic imaging are able to clarify orientation for pathology assistants, for pathologists. but it's a very actually difficult problem to study, orientation and handoff errors, because a lot of times you just don't even know that they're existing. The study that I think of in the pathology literature, it was a breast lumpectomy study, and they handed pathologists breast lumpectomy specimens with a short stitch superior and a long stitch lateral, and then a separate proline blue stitch on a different side, on a different surface of the specimen. And it turns out that 31% of the time, the pathologists were actually incorrectly denoting the laterality of that third stitch. So it's terrifying. These errors
Yeah.
are occurring and they're challenging to recognize. And I think a not insignificant minority of our pathology reports are just flat out incorrect.
That is terrifying. I hadn't heard of that. So let's get into the paper, the study that you two did and published. So this is called Ex Vivo 3D Scanning and Specimen Mapping in Anatomic Pathology. And you're using commercially available 3D scanning tools, which we'll get into later, to 3D scan specimens as they come into the gross room. And I want to go through what is the process of doing this, kind of from the moment the specimen enters the gross room, and then how that model is integrated into the final pathology report.
I think I should give the disclaimer that none of devices or software that we are currently using have FDA approval for this particular clinical use
Okay.
and are therefore performed under the approval of our institution's IRB via a research study. So we actually started to 3D scan probably when Alex was still a resident. We did our 3D scanning in the pathology room, actually in the bone saw room of the pathology lab. And we quickly realized this wasn't a great long-term solution because similarly to surgeons, pathologists don't necessarily like it if you turn off the lights. And we're using white light 3D scanning that does work best in the dark. So we actually built two separate carts that we have now. And these mobile carts allow us to basically close the door of the cart and perform the white light 3D scanning in the dark. These carts are wheeled outside the various operating rooms at our institution. Right now, we're mainly using this for head and neck cancer resections as well as bone and soft tissue sarcoma resections. But we wheel these carts outside the operating room. And then prior to the specimen being accessioned and signed into the pathology lab, we quickly 3D scan it. We've published this several times, but on average, the process takes about 8 minutes or so for the data acquisition. And then the specimen goes to the pathology lab for standard processing. And for head and neck, we try to do a lot of specimen-based margin analysis. So that's where the frozens and the margins are actually taken off the specimen.
Yeah.
On the contrary, sometimes surgeons do tumor bed-based margins where they take the margins from the tumor bed cavity. But so this is time added to the frozen section process, but these are often in head and neck, very long cases that there are nodal dissections that need to occur. There are reconstructions that need to occur. And our team, both surgeons and pathologists alike, find that 8 minutes that we spend 3D scanning on our mobile cart prior to the specimen hitting the pathology lab is time really well spent.
So yeah, from a pathology logistics side, essentially you're taking the specimen and just in the nitty gritty of it, we have a turnstile based scanner. So it's a handheld scanner mounted on a stand, and then it's on a turntable. So you put the specimen on the turntable, and on the one side, it scans it 4 times at 90-degree angles to each other. And then you flip the specimen, and then you repeat that same process. Then immediately after that point, the specimen is handed off, as Mike mentioned, but then in behind the scenes, there's someone using a computer maps the two halves of the models together, that they fuse them to make one cohesive model, kind of using anatomic landmarks. So if you have a specimen, say, that has a mandibular edge, that's a nice consistent landmark. So you can just get the two bony edges to kind of match up and make a whole surface, and then you can create the whole specimen. From there, that the specimen is handled essentially as normal. It's sectioned, it's put in formalin, with the only exception of, for the tumor mapping, so far we've used a second party as well. So one of the research assistants will come in with their computer, and then as the specimen is sectioned, they're just mirroring what is being done on the model. So when each cut is made, they have a little marker that denotes which direction you're cutting and where the cuts occur. For inking, they have the ability to color match the ink. So if you ink the posterior surface black, then they just digitally ink the surface black, etc. And then as they take the sections, they just denote on the model where each section was taken. So they just put a little white rectangle, roughly the size of our tissue cassettes, and they just put the corresponding letter to each cassette on there. So that part happens when the specimen is actually being prosected on the backside. But in between those points, essentially the normal tissue processing occurs as it would anywhere else. So that's really the main steps where this is intersected, is in the immediate acquisition of the specimen, and then as the specimen's being prosected. So we still have our normal gross description on paper as we do for every other case. We are just, for some cases, also generating an additional 3D map on top of it.
And I'll add, just to emphasize something and make clear, we currently have a separate research team member observing alongside the pathology assistant the processing of the specimen. So the pathology assistant, he or she is still doing their standard of care, written gross description, oftentimes used via at least partial dictation. And then the research team is separately making a 3D model of the resected cancer that shows the sites of sectioning and margin inking.
Okay, so it's like you said, it's an extra 8 minutes to 3D scan the specimen, which doesn't seem like that much. And it sounds like there's at least 2 extra people that are involved with this. Does that sound right?
Really just one extra person. The same person doing the 3D scanning is also mapping the virtual
Oh,
model
okay.
alongside pathology assistant. So it's really one separate research team member. Now, I will tell you, there are oftentimes more than one person there for our team, just because we've got a lot of team
Mhm.
and strength in numbers, and we're trying to scan as many specimens as possible on a given day. The preference to scan locally advanced cases that are more likely to have a closer positive margin, because that's where these visual pathology reports or 3D specimen maps are most useful.
Okay. And then we kind of covered this already, but conventional 2D photographs, like the ones we use where I work, they often fail to capture the full geometry of the specimen. The shapes of these specimens are very irregular and not typical sometimes. And I wonder then, for 3D scanning and 3D mapping of the specimens, how is that going to increase the diagnostic accuracy and communication, not only back to the surgeons, but I wonder to the patients too, maybe, especially for things like margin status?
So I think a 3D model, if a picture is worth 1,000 words, the 3D model, I'm not sure how many words it's worth, but it's worth more than 2 pictures or however many pictures you're taking
Uh-huh.
to gross the specimen. I think it's the closest thing, and I do want to acknowledge and recognize our collaborator and former Vanderbilt pathologist who's now at the Mayo Clinic, Arizona, Jim Lewis, who was also really instrumental in the development of this protocol over the past 5 years. But, he always says these 3D specimen models are the closest thing to holding the specimen in your hands. And I think that there's a lot of truth to that on the pathology faculty signing out the case side of things. So there are also, we haven't talked about this yet, we were previously kind of using off the shelf computer aided design CAD software
Oh,
for the annotation of these models. We're actively developing software for the specific clinical use of annotation of 3D representation, 3D representative models of resected cancer specimens. And this is really helping to streamline the process. I have visions and dreams and aspirations that someday we won't need a separate research team, right? Instead of using dictation software and a pathology assistant when grossing will just gross up the 3D model, or
oh,
maybe AI will automatically annotate the model as with a camera watching someone process it, or et cetera. So the thing that we're really excited about with our custom software that I think is a clear benefit to two-dimensional pictures, which at least for my cases are still only obtained, I think, a minority of the time, but is the ability to upload 2D microscopic data to the corresponding sections. So you can imagine how impactful and powerful that would be to have a model of your resected cancer. And if you wanted to view the corresponding microscopic section, you'd click that section on the model, and then out would pop your digital pathology software where you could view that actual section and any obviously corresponding stains. That's really exciting for us, and we think potentially transformative.
Yeah, I've always found that the 2D photographs can be quite helpful. You're inclined to, of course, take a photo of the tumor itself. So a lot of the time in these head and neck specimens, it's very conducive to this because one, as Mike has mentioned, the margins are usually fairly close because you're taking out the smallest piece you can because it's a very important real estate.
Yeah.
But it's especially beneficial because in almost all these specimens, the lesion is visible from the external surface. So when someone's taking a photo, they're typically inclined just to take a photo of the obvious thing. They take a photo of the lesion staring right at you. But then sometimes the subtleties don't get captured, like the other side of the specimen or how things relate. I always find if I'm looking at a 2D picture when I'm looking at a case, I always just want to like see right around the corner of what the other surface looked like, or what if I flipped it a little bit, what would have been photographed there. But it's just human nature. You capture the most obvious thing that you think is important, which would be the lesion. You don't always capture the side of the lesion, or you don't always capture what the backside of the specimen looks like. So a 3D model makes it so you can look at any surface you want. You can look at it from any angle you want, and you can really try to visualize in your head what's going on, as opposed to just trying to click through 5 or 6 images and piece together how they correspond to each other to make, signing out the case the most accurate process possible. So I think the 3D scanning offers just a new dimension to what you can view about a specimen.
Okay, that makes sense. So what about like the cut surface after the specimen is sectioned? Are you taking photographs of that? Because we know that depth of invasion is often really important.
So yeah, that's something that we're working into now, is what to do about cut surfaces. Because so far, most of the specimens we've been doing, the section starts from the surface anyways. It involves the surface. So when you're mapping this, you just kind of would show it as if it's going into the model, but then they'll just take separate 2D photographs of cut surfaces still for that purpose. But the grand vision is to integrate these slices into the imaging as well. So you can visualize it in a 3D form and then also concurrently visualize the slices so you can really put it together to see all the data you need. So right now we've been focusing on the external surfaces, but cut surfaces are also part of the equation, and it's something that we're trying to get visualized in the same way.
Okay.
Yeah, I think it would be, I'm not a breast surgeon, but I think that would be based on my experience watching those surgeries and the processing of the specimens in the gross lab. I think that would be really useful for potentially breast oncology. I also think
Yeah.
it'd probably be useful for bone and soft tissue sarcoma
Yep.
as they're trying to quantify response to neoadjuvant therapy. Alex could probably comment on that a little bit better.
Yeah, no, I think that's going to be the way to make this work for larger specimens. I think for smaller specimens, I have full confidence that what we're doing now even adds tremendous value. The next step is then finding a way to get this same value out of larger specimens. Like you mentioned, if you have a resection of a bone, like a proximal femur megaprosthesis kind of resection, or you have a mastectomy or even a lumpectomy,
Yeah.
these are bigger specimens that have a lesion on the inside, which the outside may be fairly homogeneous. It looks all like either fat or muscle or whatever. And so scanning the outside isn't as beneficial, whereas doing more comprehensive imaging of the slab, the cut surfaces, would be very beneficial as well. So that's the next phase we're at now, is finding a better way to map out these specimens in terms of slices, and you can kind of put it together in a more reasonable way than just taking flat images. So that's kind of where we're headed in that regard, of expanding this into other specimen types, as opposed to just complex small specimens where the lesion is immediately visible, working it into specimens where the lesion is central, but there still might be close margins you need to be corresponding with the mapping, et cetera.
Okay. See, that's particularly interesting to me. I'm a pathologist assistant, and you're talking about the grossing process here, which from what you're saying could radically change. But that's exciting to me. I like thinking about how that could be, because it would be more accurate, and it probably eventually would be faster too. All right. So we talked about the advantages of this scanning and the things you can do with it. I wonder though, getting this up and running, were there any particular challenges that you had to overcome to do it?
Well, the big issue up front was when you tell someone, hey, we know we're trying to go for 20-minute time turnaround on a frozen section. We're going to add 8 to 10 minutes into that. So as Mike was saying, it took a little bit of time of really just showing the value. So it worked out well when you had kind of a combination of someone who was a head and neck pathologist doing frozen day, and then you had someone like Mike or another surgeon who likes this kind of thing together, so they could kind of communicate upfront about it, and then the expectation would be set that even if it's going to take a little longer, it's going to be more accurate. So we can let this process play out and then go from there. But that was definitely the biggest issue, and also the space component. So as Mike mentioned, the early rendition of this was just a person using we have a room that had in our former lab. We've since moved offsite all our pathology operations to an offsite lab. But at the time, we were right next to the OR, and we had a pretty limited space already for the gross room. And then there was an even tinier room that had the bone saw, and then you just had like all the flammable material storage in this teeny tiny room. So if someone was having to use the saw for any reason, it was very disruptive if you had a person with the door shut trying to scan specimens for 10 minutes at a time. So those were the initial growing pains, was just first showing that this had value. And then once people started to realize it was valuable, then we could start fine tuning the process to have these carts that are more discrete for the purpose and are more mobile, and it could be operated in different areas besides this one specific place. So really just getting people to see that this is something worthwhile. It was not hard, but it was just, you had to just prove that there was some benefit to this, which I think once we did, it's been fairly reasonable from there. Now, just as Mike has assembled his team to really streamline the process, it's gotten easier and easier.
Yeah, and I'll emphasize, we just worked very hard in the beginning year to 2 years to make sure that we did not interfere with normal surgical pathology workflow, that specimens were not being mishandled, that anatomic orientations were not being affected, that frozen section turnaround times were not significantly being increased. So it was just a lot of very careful intervention in the beginning to build trust amongst our surgical colleagues, amongst our pathology colleagues. And when we had that trust, we were able to also just put on top of it all the value that these add. And then we got quick buy-in.
This is the People of Pathology podcast with our guests, Dr. Michael Topf and Dr. Alexander Perez. We'll be right back.
Are you thinking about applying to a pathologist assistance program and feeling a little lost? That's why I created the Path to PathA, your PA school application blueprint. This is a step-by-step prep course that gives you everything you need for a strong application. From finding shadowing to writing a standout personal statement to prepping for interviews, this course was made to help you feel informed, confident, and ready. Visit www.thepathtopatha.com to join the mailing list. You'll be the first to hear when the course launches. Your path starts here.
LabVine is an interactive online learning platform where laboratory professionals learn, develop, and discover by sharing knowledge and building on each other's experience. The platform provides global access to internationally accredited laboratory-specific courses and other resources developed by lab specialists like us for the laboratory industry. LabVine is free to sign up, and you can use the link in the show notes to get started. And now for the rest of my conversation with Dr. Alexander Perez and Dr. Michael Topf on the People of Pathology podcast.
Something else I wanted to talk about, and I don't remember if you covered this in the paper as well, but the potential not only for the current case, this 3D image for the current case is useful, but I think there are other uses for something like this, things like tumor boards or educating residents and students, things like that. Are you using, or are you planning to use these images for those purposes?
Yeah, in the paper, we'd only briefly kind of touch on this in kind of future directions as far as what we could do with it. But I think all of these things have a lot of potential. So for education right now, a lot of medical student education relies on cadaveric organs and such like that may have an example of a disease that, as a good example, can be shown over the years by preserving it in formalin. But as things just in the whole world trend more digital, there's a lot of opportunity for this to be applied in that context as well. If you have, say, something very classic like a cirrhotic liver or something, you could easily just have scanned cirrhotic liver so they can correlate with the gross images they see, the gross specimens they see. But then when they're reviewing and studying or whatever, instead of having to just think back in their mind to what it looked like or look at still images or whatever, you can just have a model available and you can see a very high resolution example of whatever pathology you're trying to see. tumor board, this is definitely is something we do as well. We'll show these models of the tumor board. If you're saying the margin is less than zero point 0.1 centimeters, you could just show them, hey, here's the slide. This is what I'm seeing. This is the exact spot on the specimen where it came from. And so if they're planning to re-resect or whatever, you can be much more granular with where you're telling them you're positive. You're not saying, oh yeah, it's somewhere on the medial. You're saying, hey, this is block M. I'm showing you exactly what it relates to. And then everyone in the call can just see this is exactly where the margin was positive. This is where it was far. This is where it was close. And it can just really explain a lot better, what is close or what's there. So tumor board benefit, I think, is tremendous because again, in that room, there's one surgeon, maybe their trainee who was operating. There was maybe one pathologist who had the case, but then anyone else in the call can pretty much get up to speed quite quickly on what the specimen was all about when you can just see a representation of it and just kind of pan around all 6 spaces of it. So those are 2 tremendous things. And then of course, as you well know, specimens have to be discarded at some point.
Right.
We like to keep them as long as we can. Usually there's about 2 weeks after the case is signed out. We get rid of them in accordance with regulatory protocols. Now, in this instance, these scans are even at their biggest, like a couple hundred megabytes. So you can pretty easily just store these for a much longer period of time. And so even if a patient has a recurrence 2 months or 2 years down the road, you could just easily recall that specimen and have the original specimen, the original path slides, the original report and everything for review quite easily, as opposed to the current situation, which is where the specimens unfortunately just have to be discarded after a certain period of time. So you have this durable representation of the specimen, which you can use for really a variety of purposes.
Yeah, we are having so much fun now that we have this novel source of data. We worked really hard in the first, I'd say, 2 to 3 years to, as we alluded to previously, to not interfere with normal surgical pathology workflow. And now that we have built it, I think we're close to our 400th case. This is the type of protocol that is happening on a daily basis at our institution, and we are really starting to have fun with the data. As Alex alluded to, we earlier this year in February 2025, we published in the journal Head and Neck. Carly Fassler, one of our team members, is the primary author on that. The visual pathology reports improved collaboration at multidisciplinary head and neck tumor board. What we did is for 10 straight weeks at our tumor board, we actually showed a QR code of at least one case. And that QR code actually opened a browser on the end user, typically oncologist's phone, and they were able to manipulate the 3D model on their phone. It's actually, the software is fairly intuitive. We partnered with a commercial partner, MedReality, for that. And in that study, our pre and post intervention survey showed that it significantly improved providers' understanding of where margins were taken, as well as in providers' confidence in adjuvant treatment plans. So we're super excited about those results and encourage any listener to take a look at that publication. We are, I think, about halfway, maybe 2/3 of the way through a study where we are 3D printing these files and providing patients with them, and kind of assessing their response to having resin 3D printed model of their cancer. Is that something that patients like? Is it something that is going to empower them? Is it something that's going to help them understand their disease process or make them more likely to adhere to their adjuvant treatment? We're actively investigating that via an IRB approved study. We similarly just finished the data accrual and are kind of actively analyzing the impact of providing a radiation oncologist with a 3D file or a 3D printed model of a resected cancer. Does that allow for more targeted adjuvant radiation therapy after surgery? It makes a lot of sense that it may. So we are analyzing that data currently in a small kind of pilot study of, I believe it was 13 patients. We've also had some fun where, actually when you ask a surgeon to relocate a soft tissue point, to go back into a tumor bed defect and take out more or residual cancer cells or more widely clear a close margin, turns out that surgeons, despite thinking that they know where they need to go, they're actually off. The head and neck, one study showed even when you ask a surgeon to relocate a soft tissue point 5 minutes later, they're off on average about a centimeter. And
Wow.
we know that frozen section process for multiple frozens for, let's say, a head and neck cancer case, I mean, we may not get those results back for 30, 40, 50 minutes, right? For a challenging case. So that is part of the reason why clear the first time does not equal initial positive margin, and that is subsequently cleared in terms of both local control and survival. So we got the idea, and I credit one of our team members, Kavita Prasad, who published this in the Annals of Surgical Oncology back in 23. But we started uploading the resected cancer models, 3D models, to an augmented reality headset. We've used both the Microsoft HoloLens 2 as well as the Apple Vision Pro. And we then place that hologram back of the resected cancer specimen back into the defect in real time during surgery. Mainly have done this in the preclinical kind of cadaveric model, but have also done this in actual patients in non-intervention manner, and demonstrated that surgeons could much more accurately relocate soft tissue points with the augmented reality guidance to an accuracy of as little as 2 to 4 millimeters. And similarly, are now working on kind of custom software with collaborators from the Vanderbilt Institute for Surgery and Engineering. Ying Wu is a PhD collaborator that I work with in computer science, as well as Mike Miga in biomedical engineering. We're working on custom software that basically deforms the specimen back to its initial state, because we know that there is some shrinkage that occurs with the cautery and excision of the tissue, and then auto registers the specimen back into the defect. So a surgeon, if he or she had a closer positive margin, could use that as an automatic guide to take out more tissue. So just a few examples of all the fun that we have been having with this novel data source.
That's amazing. There's a lot of options there. I mean, I'm mostly focused on the pathology aspect of it, but the surgical kind of innovations that could come out of this are amazing. And the fact that you can show the model to the patient, I think you said you've started doing that already. Is it too early to say what the patients have thought of this, or how?
Yeah, we started doing this for about halfway, 2/3 through a study,
Okay.
and I would say, I haven't looked too much at the data, but kind of qualitatively, I'd say about 3/4 of patients really like the model and feel that it's educational and empowering. About a quarter of patients are kind of turned off by it.
I can
So,
see that.
so it is a mixed response, but in general has been favorable thus far.
Interesting. A lot of options for future work on this for sure. The last thing I wanted to talk about is, because it's a new technology, and I'm sure some people are thinking, okay, this is going to be very expensive and we won't be able to afford it to use it. But you give the equipment that you use, you describe it in the paper. So I looked it up online just to see how much it costs. And it's around $2,000, a little bit more. So the price tag barrier is not really there for this. So could you comment on this? Like, what would you say about labs that are hesitant to invest in this kind of technology?
Really, I think it's more daunting from a understanding how to use the tools software than it is from a cost perspective. Like you're saying, I mean, $2,000 is not nothing by any stretch, but when you're, proposing an entire lab's budget, I mean, it ends up being a drop in the bucket for any reasonably sized lab. So
Yeah.
really where the barrier would be is in how you're going to implement this. So the challenges would be in, first off, making sure that the people, the pathologists, the surgeons where you're at seem to have interest, and if they share the same appreciation of the value that we do and have tried to show, but really just making sure you can get it integrated into your workflow in a reasonable manner. So if you have the tool, understanding how to scan the specimen properly, how to get the proper environment to get good results and not get discouraged when the models aren't perfect up front, and how to kind of troubleshoot getting the two halves of the model together. All of those things kind of factor into getting the adoption, because as Mike alluded to, once we got things going and once you showed what it can do, everyone is all on board. So really what you need to do is just get that initial step of showing them the first couple really nice looking crisp models that you've made, and then showing how beneficial it is. And then people tend to be quite receptive to this technology. So if people are hesitant, there's going to be a learning curve. There's just no two ways about it. We happen to have some people who were pretty technically adept, who had prior experience in 3D modeling and scanning before. So that helped us get on our feet, because like you'd imagine, having someone who knows what they're doing with it and can make a nice looking product gets people on board. So
Sure.
there's going to be a learning curve. It's going to be difficult in the beginning. You're probably going to think, well, I should have just taken a couple more gross photos. Maybe if you even did a photo shoot that takes 10 minutes, you could still probably get something decent as opposed to messing around with this model for a while if they don't know what to do with it. But if you get adept at it, it's really nice. And there's really nothing else that compares to this level of detail that you can convey. The cost part is a really nice component of it. This stuff is just hobbyist level stuff. People use these kind of scanners for car parts or for scanning computer components, whatever they're going to 3D for. So it's kind of put at that price point where like a reasonable person who enjoys something but isn't like rolling in money can afford to have it. So even with this level of material, which is like not the highest end by any stretch, but it does really well. So I thought it was important to show that you can do this kind of stuff without these industry level tools. This is just regular stuff you can just get on the internet quite easily. So as long as people realize there's going to be a little bit of learning to do when you get it, they're really, you can get so much benefit out of these without a ton of investment on the financial side.
Yeah, totally agree with all that. I think the stuff, the technology and hardware we use is slightly more labor intensive, just because we do try to keep the hardware costs down. Less than $2,000, certainly probably going to be acceptable to most labs, but it does require, a team member that is going to learn the processes. Now, I will make the announcement that if anyone, any lab is interested in this, please contact us, because we do have kind of lab manuals that take you through step by step, and would be happy to share them with you. We very much are of the mindset that we think that this is the future of gross pathology, of surgical pathology, and it's going to take more teams and labs adopting it to realize that. So please reach out if you have any interests. I will say there are more expensive, fancier 3D scanners that are less labor intensive, where it's more, you just push a button and you get your 3D model. And those are, with that ease of use comes increased cost, but that is something to explore as well. And I'll just add, I think the Mayo Clinic, which is a very, in my opinion, forward-thinking and innovative academic medical center, is implementing many of these 3D scanners in their gross labs at various campuses. So I think that's a signal that perhaps this is the direction that the field is going. And I'll just emphasize one more time that all of our 3D scanning work is not, and there are, to my knowledge, no FDA approved 3D scanners of surgical specimens.
Mm-hmm.
I would love for one of the hardware companies to take that on. There are intraoral scanners that are approved for dental use. You may see at your dentist, but for surgical specimens, to my knowledge, there's no FDA approval, and therefore we do everything under an IRB.
And I do also want to emphasize, if anyone listening to this, if they have any interest, please feel free to reach out. That's actually how we ended up with this opportunity to speak with you today. Is one of the residents in pathology at the University of Michigan, Meredith Herman.
Yeah.
She just saw the paper. She thought it was neat, and she reached out to Mike and I, and then they put us in touch with you and said that she wants to try to get something going at her institution with this, and she thought people may want to learn more about it. So I think that it's great in this world. It's very collaborative and it's very easy to get in touch with people. So please, anyone, feel free to reach out if you want to discuss, or if you have any questions about implementation at your own institution.
Yeah, I'll link the paper in the show notes so that people can read the paper and they can contact you if they would like.
Awesome.
Okay, this is really fascinating stuff for me. Like I said, I'm very much interested in this stuff, and it sounds like there's a real potential for this technology. So I appreciate both of you coming on and talking about this. So Dr. Michael Topf, Dr. Alexander Perez, thank you both very much.
Yeah, thank you so much for having us.
Thank you so much for the opportunity. This was really fun, and hopefully we get some interest from some others across the country. It's actually kind of surprisingly pretty easy to do this, and in my opinion, it just makes too much sense.
If you're looking for another episode of the People at Pathology podcast to check out after this one, here's a clip from my interview with Dr. Sofian Azdad, as we talk about why improving pathology workflows might be an ethical issue.
It should be unacceptable when errors occur due to non-systematic flaws, like a simple label mix-up caused by a process we all know is vulnerable. We know the workflow isn't perfect, and most of people are doing their absolute best within that system. But the ethical issue arises when we know We are placing human beings in the critical roles, asking them to perform tasks all day long that the human brain is simply optimized, like a constant checking, etc. So if we recognize this vulnerability and potentially know that better methods or technology exist or could be developed, and if we know that and yet we do nothing tangible to improve that weak point, that's where the ethical problem lies.
You can hear more from Dr. Soufiane Azdad in episode 204. All right, big thanks to Dr. Michael Topf and Dr. Alexander Perez. This was a really fascinating conversation. Obviously, I love talking about bringing technology to the grossing process since it directly affects my job. So, in traditional pathology workflows, especially in complex cases like head and neck resections, so much important spatial information can get lost. As Dr. Perez pointed out, the process often resembles a game of telephone. The surgeon sees the full three-dimensional specimen, the PA documents it in text while grossing, and the pathologist later interprets that description without ever seeing the intact specimen. It's a system that works, but it's not without its flaws. And those gaps in communication can have real consequences. That's where 3D scanning comes in. Dr. Topf and Dr. Perez walked us through how their team is using commercially available scanners, equipment that costs around $2,000, to create high-resolution models of surgical specimens. These models can be rotated and annotated. The best part? This technology integrates into the workflow with very little disruption, adding only about 8 minutes to specimen processing. For a tool that can dramatically improve accuracy and communication, that's an incredibly small trade-off. The impact is already being felt across multiple settings. In tumor boards, these 3D models provide surgeons, oncologists, and pathologists with a much clearer picture of margin status and specimen anatomy, leading to more informed decision-making. For radiation therapy planning, the ability to correlate scanned specimens with imaging could make treatments more precise and reduce side effects for patients. And in medical education, trainees now have the chance to interact with realistic models, or even 3D printed replicas, to deepen their understanding of anatomy and pathology in a way that traditional slides and photos just can't provide. Beyond the clinic and the classroom, there are also exciting possibilities in patient care. Imagine sitting down with a patient and showing them a 3D printed model of their tumor, helping them visualize exactly what was removed and why. Or picture an augmented or virtual reality environment where these scans are integrated directly into surgical planning. The opportunities are vast, and we're only at the beginning. What had stood out most in this conversation, though, was the spirit of collaboration. Both Dr. Topf and Dr. Perez emphasized that their protocols are designed to be shared. They want other institutions to benefit from this technology and are eager to support adoption elsewhere. While their current work is under IRB approval and not yet FDA cleared for routine clinical use, the fact that large institutions like Mayo Clinic are beginning to explore similar workflows suggests that it isn't just a passing experiment. It just might be a glimpse of the future of pathology. This episode is a reminder that innovation doesn't always come from massive investments or overly complicated systems. Sometimes it comes from taking a widely available tool, applying it to a new context, and being open to change. And in this case, that simple but powerful idea may transform how specimens are documented, how pathological findings are communicated, and ultimately, how patients receive care. As always, I'll have links in the show notes to everything that we talked about today. Don't forget you can follow this show at People of Path on both Instagram and Twitter, or just connect with me on LinkedIn. Thank you for continuing to share the show with others. Together, let's inspire the next generation of pathologists and laboratory professionals. This show is a member of Health Podcast Network. Thanks for listening. I'm Dennis Strank, and I'll talk to you next time on the People of Pathology podcast.